So, hi guys, welcome. Today we're going to be talking about poisoning. And under poisoning, this can be acute or chronic. So, acute poisoning is often life-threatening and should be always be treated as an emergency, even if immediate threat to life does not appear to be real. So, clinically, the patient is going to present with their blood pressure. So, we have to monitor blood pressure. We have to monitor urine output. That means you have to catheterize the patient. We have to fix an esophageal suction in abdominal conditions. Blood glucose levels have to be checked and HB levels post PCV daily and correct appropriately. You have to monitor that. So we also have to treat renal complications appropriately and more importantly, treat the cause of the hypovolemia to preempt these complications. So preventive measures, we have to do public education about household chemicals known to cause accidental and parasuicidal and suicidal poisoning. So straight up, we go to different types of poisoning. We have household agents and industrial chemicals. We have pharmaceuticals. We have pesticides. We have others that are not in this category that we're also going to look at. So straight up, we go to household and industrial chemicals. So first of all, we have kerosene. So kerosene ingested poisoning, the patient is going to present with nausea and vomiting, cough, pulmonary irritation, difficulty in breathing, headache, and loss of consciousness. So, how are we going to manage this? We have to remove contaminated clothing that the patient is putting on, wash exposed skin with water and soap. We also have to give activated charcoal to maintain airway and respiratory support. So, here we do not induce vomiting or perform any form of gastric lavage. We also have carbon monoxide, example car exhaust and charcoal geckos that cause poisoning. So the patient is going to have headache, dizziness, confusion, slurred speech, convulsion, coma, symptoms that vary with the percentage of carboxyhemoglobin in the blood system. Here we treat this by giving 100% of oxygen and a hyperbaric oxygen. We also have corrosives such as acid, alkalis, and hydrogen peroxide. So here the patient is going to present with exhalating pain in the mouth, the pharynx, epigastric area, dysphagia, vomiting, and hypothesis. So later develops a laryngeal edema and obstruction. So esophageal perforations long term presents and also have stenosis of the esophagus. Here we manage this by giving liberal water or milk orally. We also have to give analgesics so as to maintain and relieve pain. So we do not induce also any form of vomiting or perform any form of gastric lavage. Next, we go to methanol. So the patient is going to present with intoxication, signs such as drowsiness, muscle weakness, blood vision, photophobia, papilloedema, blindness, coma, cerebral edema, cardiorespiratory depression, seizures, and may also result to death. Here we manage this by giving IV sodium bicarbonate, 10% ethanol in 5% of dextrose, and we give it orally or via IV infusion. We also have to give a loading dose of 0.7 grams per kg over 1 hour and maintain at zero point 0.1 to zero point 0.2 per kg per hour up to ethanol levels of 100 milligrams per deciliter. Straight next, we go to pharmaceuticals. First, we have paracetamol. The patient is going to present with nausea, vomiting, altered mental status, abdominal pain, evidence of liver failure. So we have elevated transaminase. So here we do gastric lavage within the first hour. Activated charcoal is given, and an antidote therapy with acetylcholine for up to 72 hours. We also have chloroquine. So the patient is going to present with convulsions, cardiac arrhythmia, and also cardiac arrest. So here we also do a gastric lavage. We give IV diazepam for the convulsions, and in case there's any form of coma, we can refer for intensive care unit. We also have digoxin. In digoxin, the patient is going to present with arrhythmias, ventricular fibrillation, anorexia, nausea, vomiting, confusion, abiophilia. So here we manage this by discontinuing the drug, administer potassium, so treat any arrhythmias with lignocaine or phenytoin. We also administer antidigoxin FAB fragments so as to maintain that. We also have iron tablets such as vitamins and ions. So here the patient is going to present with vomiting, abdominal pain, pallor, cyanosis, diarrhea, and shock. So here the patient is going to present with the maces. A gastric lavage is supposed to be done. You also have to give desferoxamine 1 gram IV, 15 milligrams per kg per hour, at a maximum of 80 milligrams in 24 hours. So we also have opiates and narcotic drugs abuse. So the patient is going to present with drowsiness, pinpoint pupils, shallow respiration, also going to present with respiratory failure and sparsity. So here we manage this by not giving emetics. We do a gastric lavage. We give activated charcoal. Also give naloxone 5 IU per kg in IV to awaken and improve respiration. Also give IV fluids to support circulation. So here we also have isoniazid. Here, the patient is going to present with CNS stimulation, seizures, and a coma. We manage this by emesis, gastric lavage. We also give diazepam. We also give pyridoxine 1 milligram for 1 milligram ingested up to maximum of 200 milligrams. We also give sodium bicarbonate for acidosis in the blood. Another poisoning can occur with warfarin. So the patient is going to present with a generalized bleeding with the intracranial hemorrhage being most serious. Here we manage this by giving vitamin K 10 milligrams IV start and OD for 5 days. We also have to transfuse fresh blood. Thirdly, we go to pesticides. Under pesticides, we have organophosphate poisoning with such as diazenon and diamethate. So the patient is going to present with headache, weakness, vomiting, colicky abdominal pain, profuse cold sweating, hypersalivation, muscular twitching, fascication, diarrhea, tenesmus, convulsions, dyspnea with bronchoconstriction. They also present with meiosis and bilateral crepitations. What do we do here? We do decontamination. We also have to do remove contaminated clothes, wash the exposed skin with water and soap. Here we also do not induce any form of vomiting. We give IV atropine 2 to 4 milligrams start. Repeat after 10 to 15 minutes until atropinization is achieved. Here we also have to monitor pulse to ensure that it doesn't exceed the range between 100 to 120. We also have check out for dilated pupils. Also have to maintain on subdued atropine for 4 to 6 hours for at least 24 to 48 hours. Also give pyrolaxidone, um, 1 to 2 grams for children. It's 30 milligrams per kg. You also have to give a start and repeat 4 hourly, 12 to 24 hours, depending on the response. Next, we go to rodenticides such as zinc phosphide. Here, the patient is going to present with severe abdominal pain, nausea and vomiting, diarrhea, strong garlic smell, severe respiratory distress, and myocardial injury. Here, all we do is supportive care. We maintain the patient on an airway. Uh, if the patient GCS goes down, we can assist by ventilation. We observe for pulmonary edema. We also give and make sure that the patient is vitally stable. We also have rodenticides that are anticoagulant based. So the patient will present with generalized bleeding with intracranial hemorrhage being the most serious. Here we just give vitamin K 10 milligrams IV start and transfuse fresh blood. Well, also we have acasicides such as amitraz. So here the patient is going to present with weakness, difficulty in breathing, convulsions, and a coma. So here we remove contaminated clothes, wash out exposed skin, with water and soap. We do not induce any form of vomiting, but instead we give IV sodium bicarbonate. We also have herbicides such as praquit. So here the patient is going to present with oral pharyngeal inflammation, lateral multi-organ failure within hours or days, depending on the dosage that the patient has induced. Also later interstitial pulmonary edema and fibrosis, and also multi-organ failure and pulmonary edema, invariably leading to death. Here we give little doses as low as 10 mils. We do gastric lavage with 50 to 100 grams activated charcoal for hourly until the patient gets to improve. We also have organochlorines such as DDT and aldrin and daldrin. So here the patient is going to present with extent tremors, convulsions with respiratory failure due to convulsions. And we manage this by giving IV diazepam for the convulsions. We do a gastric lavage if within 1 hour. We also have to do survivors beyond 48 hours, almost incredibly, to recover. So you have other forms of poisoning that include lead, such as lead soles, solders, toys, paint, and painted surfaces. Here, the patient is going to present with thirst, abdominal pain, vomiting, diarrhea, encephalopathy, following ingestion of suspicious substances. How do we manage this? We manage this by eliminating the source of poisoning. We give chelation with diamicoprol injection 4 milligrams per kg and combined with calcium sodium editate with close monitoring for renal function. Here we also have to monitor the input output. And finally, we have poisoning by mercury. And here the patient is going to present with acute gastroenteritis, vomiting, nephritis, anuria, delayed GI motility. Also have chronic cases where the patient is going to present with gingivitis, mental disturbance, and neurodeficits, and pneumonitis also. Here we manage this by giving gastric lavage, activated charcoal. Also give penicillamine and hemodialysis for renal failure. Also have to look out for GIT perforations, and also for the lungs, we also have to do supportive care. And here best you can put our patients on a ventilator. So that's how you can be able to manage most of the forms of poisoning. And the most important thing is creating awareness. If any form of poisoning has happened, kindly make sure you seek medical attention. Thank you.